Hello, everyone. On behalf of the American College of Cardiology and the Center for Systems Improvement, we'd like to welcome you to the EMS and Systems of Care webinar series, Taking Clinical Quality to the Next Level. I'm Tom Boothele, and I'll be one of your moderators. Joining me as moderator is Tim Phelan. Tim is an educator specializing in training for acute coronary syndromes and ECG interpretation. He's the author of several textbooks on ECG interpretation for acute myocardial infarction. And over the years, he has taught over 100,000 providers in the United States and overseas, including yours truly. As a matter of fact, Tim, I think you may have taught the only formal 12 lead class I've ever had. I think that was probably in 1999 or 2000. You're really a man that requires no introduction at all. In the past, I've referred to you as the Pope of EMS cardiology. And I know you can't tell because it's a webinar, but I'm genuflecting. I'm kissing your ring digitally. So
I'm humbled and I won't ask you to kiss my ring. Okay. So Tom, thank you very much. See, I was about to say all these amazing things about Tom. So I don't think anyone is listening, or I think everyone listening is familiar with Tom. He's a battalion chief with Hilton Head Fire Department in South Carolina. He's a program director for the Resuscitation Academy there in South Carolina. He serves on the High Performance CPR Working Group. He's on the editorial advisory board for EMS World. And if you don't know from any of that, you probably know him as the editor of the most awesome site, ems12lead.com.
this is the second installment of this webinar series, and it's on structuring your organization for quality. The video recording this part of this webinar will open up in a pop-up window, so disabling pop-up blockers on your browser may be helpful if you experience problems seeing the video. After the video portion is completed, we'll return to our live session for questions, answers, and discussion.
As you go through this webinar with Mick, I guarantee you there will be so much substance here. I suspect everyone is going to have questions. So two options. If you're watching live, at any time, you can enter your question into the question box in your control panel. And Tom and I will do our best to cover as many of them as we can during the live Q&A portion immediately after the webinar.
If you are watching the archive replay recording of this webinar, please feel free to send questions and comments to Mick, that's M-I-C, at improvethesystem.com. The archive recording will be posted within a few days after the live session with an email notice and viewing link sent out to everyone who registered for the event. Mick will do his best to respond to questions and comments sent in by email.
So we're about to begin the main event here. And Mick Gunderson is our leader, and it's his webinar that he has put together. So I have known Mick for over 30 years. I often tell people he's the smartest human I've ever met. I'm pretty sure at age 5, he built an interplanetary scooter from things that were just laying around the garage. So you are definitely in for a treat. If you don't know Mick, here's what I can tell you about him. He's had an over 40-year background in EMS and quality and cardiovascular care. The American College of Cardiology is collaborating with Mick at the Center for Systems Improvement to develop a wide range of EMS and system of care programs and services to improve cardiovascular care. So let me turn it over to you, Mick.
Well, thanks for the kind introduction, guys. I'm really delighted that you're both here to bring your expertise and insights to the discussion. We're going to start the video segment now, so there will be a brief pause while we get that started. So bear with us for just a moment. Pop-up should come up on your screens momentarily.
This EMS and Systems of Care webinar series is supported by the American College of Cardiology's National Cardiovascular Data Registry, the NCDR. Later this year, they will be rolling out a new service to take support of quality improvement for EMS and systems of care for acute myocardial infarctions to a whole new level with NCDR eReports EMS. We're going to show a short video, just under 3 minutes long, that provides an overview before we get into today's topic.
Feedback to EMS on STEMI patient outcomes is important, but EMS quality improvement programs also need the details on the processes of care they impact. The format for these details must allow for all STEMI cases to be aggregated This helps identify where procedures, protocols, policies, and education can be adjusted to increase performance across the entire EMS agency. However, hospitals may not have the resources to assemble all of the process details and outcome data elements in a timely manner for EMS quality improvement. If EMS brings STEMI patients to multiple hospitals in their service area, then it becomes all the more difficult to bring all this data in different formats from different hospitals together into one report that reflects on the overall EMS organization. Fortunately, many hospitals that perform emergency PCI in the U.S. participate in the clinical registries offered by the American College of Cardiology's National Cardiovascular Data Registry, NCDR. These hospitals enter detailed information on each patient who meets inclusion criteria for a registry. That information is then processed and performance reports are calculated by the NCDR. The reports show performance trends and compares individual hospital performance to their historical trends as well as state and national benchmarks. NCDR's chest pain MI registry captures several EMS-related data elements often obtained by hospitals from the EMS patient care reports. With the EMS and hospital data elements, the NCDR can calculate and aggregate performance measures in a quality report that can help drive improvements in EMS and STEMI systems of care. To make this information available directly to EMS, the American College of Cardiology is proud to announce an online, on-demand national EMS and systems of care performance reporting tool for STEMI cases, NCDR eReports EMS. NCDR eReports EMS is built on the well-established NCDR eReports platform used by health systems nationwide. It provides on-demand reporting to track clinical performance and guides quality improvement initiatives. NCDR eReports EMS will launch soon. For more details and information on how to enroll, visit acc.org/eReportsEMS.
When the product is ready to roll out, the ACC will have a separate webinar to walk you through all of its features, functionality, and how to enroll. Now, to put today's content into better context, it'll be helpful to briefly recap what we covered in the first one, making the leap to improvement science. In that first webinar of this series, we started out with the discussion of some of the key developments in the history of quality and how manufacturing moved away from the craft guild apprenticeship model into the scientific management approach. We saw how that was a breakthrough, but had significant limitations due to quality issues stemming from a failure to utilize the insights of frontline workers. We saw how innovations from people like Schuhart, Duran, and Deming transformed quality beyond scientific management into a new model that embraced direct frontline worker participation and improvement. We saw how the healthcare sector lagged behind manufacturing in their sophistication about quality, but how healthcare is now making significant progress spurred on by public accountability programs, pay for performance, and alternative payment models that are pushing healthcare providers to improve clinical quality while simultaneously reducing total systemic costs. We also saw how the EMS discipline is starting to step up by establishing nationally standardized performance measures, first with the EMS Compass Project and now through its successor program, the National EMS Quality Alliance. In this second module of the series, we're going to explore how the typical designs used in healthcare organization quality programs may be severely limiting their capacity to conduct improvement projects, and how those designs may also be limiting the scope of staff participation. We'll then look at the key elements of what we call the team-based clinical quality program model and show how it can be used by EMS agencies to dramatically increase their capacity to do improvement projects. We'll also see how the model opens up some very interesting clinical career pathways. The examples will be EMS focused, but many elements of this model can translate into a hospital setting as well. Now, in many healthcare clinical quality programs, the overwhelming majority of work is done by a very small number of staff members, typically with some sort of quality or clinical manager job title. In most EMS agencies, it's just one person. In hospitals, it's often one person per major service line, like the cardiovascular service line, designated to address quality. They might have a title like the cardiovascular quality or care coordinator. These individuals in EMS and in the hospitals work very hard to collect data and generate reports on clinical performance, which are then shown at regularly scheduled management meetings, where the performance results shown in the reports are discussed. Not that any of this is bad, but after gathering and entering the data, generating the reports, investigation and resolution of any complaints and incidents, supporting or running the continuing education program for that clinical area, and attending to their other duties as assigned, often these key individuals are left without much, if any, additional time to facilitate actual improvement projects. Therefore, improvement projects often get bottlenecked by the limited bandwidth of these key individuals. Another dimension to this all too common status quo is the lack of staff development activities to prepare individuals that come into these key clinical management roles. Too often, particularly in EMS, we see an excellent clinician promoted into one of these quality manager positions and then getting little or no formal training in quality. There usually isn't a well thought out plan for their professional development in these roles beyond maybe attending a couple lectures or a pre-conference workshop. This position is too important to not give serious consideration to the selection, initial training, and continuing professional development of the knowledge and skills for the person serving in this important role. The hospital community has better addressed this with training and credentialing programs for clinical nurse specialists for various clinical areas, but EMS is way behind in this regard. Adding more staff into these clinical quality roles can increase some capacity for more projects, but that's often the most expensive solution. It also might not get the best results. But this strategy is popular because it's often easier to just throw money at an issue when you're a larger organization than trying to challenge the status quo by rethinking and experimenting with new ideas to see how the needs of the organization could be met more efficiently. And adding more positions is not even feasible for most middle to smaller sized EMS organizations. And hospitals are usually confronted with similar realities. So how might EMS agencies and hospitals overcome these barriers? That's what this webinar is going to take on. We're going to lay out a rough template of an organizational structure that could be incorporated into many EMS organizations and hospitals. The idea is to improve the capacity of these organizations to conduct QI projects, get more people involved, and establish some accountability for actually moving things forward, not just generating reports on PowerPoint slides about the number of IV starts last month and other low-value information for a committee meeting. I like a well-crafted slide as much as anyone, but another pretty graph of things like how many IVs were started last month is not the end game here. What would be much better is a quality strategy that's capable of producing a data visualization like this, showing the changes in performance of a key metric over an extended period of time with notations on when various improvement initiatives were implemented over the last few years. This would show frontline staff and the management team the long-term impact of their efforts and put the efforts of their latest initiatives into better context. Let's consider the approach taken by many of the firms in the manufacturing sector that have much more mature quality programs. Decades ago, many of them implemented strategies to directly engage frontline workers in the core of their quality programs. There were several variations on this approach, and those approaches have evolved over time, and many different names were given to them. But the most commonly used name early on was the quality circle. The basic premise of the quality circle is that frontline workers who directly work inside the processes connected to their jobs, day in and day out, gain deep insights into those processes. If properly coached and supported, those workers, with their insights on how the processes actually work in the real world, could generate great improvement project ideas, be directly involved in project implementation, and help train their colleagues on any changes being made to their processes. Hospitals sometimes have structures akin to quality circles in which they have a committee of subject matter experts in the area that the committee covers. For example, cardiologists and cardiovascular clinical nurse specialists will be on the hospital's STEMI committee or a more general cardiovascular service line committee. It will usually include some members from the emergency department and from the cardiac cath lab staff. Sometimes we even see folks representing EMS, which is terrific. But far too often, many of these team members don't get sufficient training in the tools and methods of quality, which limits their contributions to the team, and it places more burden on those key quality and clinical management staff members that we've been talking about. It is also very common for the same people from the emergency department and the EMS agency to be asked to be on all of these various emergency care-related hospital service line committees. And it's typically that one person in that emergency medicine and EMS clinical quality manager role who is assigned to those committees. Again, it's a bottleneck with that one person needing to be on all those committees. Inside an EMS provider organization, we might see the quality manager and EMS medical director in the senior management team meetings where some sort of EMS clinical performance measures are reviewed. And actually, that's just in the better performing organizations. More typically, and quite unfortunately, clinical performance is not routinely reported and discussed at senior EMS management committee meetings. More commonly, clinical topics are only on the agenda when there's a problem that has to be fixed. It's stereotypical administrative firefighting. The quality circles model suggests a different strategy. I think that the EMS industry can reboot the quality circle concept into something new for contemporary EMS. In our reboot, let's consider establishing a quality team for each of our major clinical areas. Let's find a way to have frontline staff actually run these teams, and let's have these teams take responsibility for monitoring performance and catalyzing improvements in their respective clinical areas. Let's empower them to make changes and have some accountability for actually getting things done so we can start to see some measurable progress. So our quality circle reboot is what we call the clinical specialty teams. Some elements of this closely align with the hospital's clinical service line committee we just talked about, so I'm going to focus the examples for this idea on EMS. Consider that in the legacy manufacturing quality circles model, frontline worker participation in the quality circle for their work area was an integral element of the worker's job description. It was not considered a nice to have, but a must have. As a result, the participating frontline workers were trained to at least a very basic level in quality concepts, tools, and practices, right along with the training on the tasks of their manufacturing, service, or support roles. Translating this into EMS, we should consider participation in quality initiatives also an integral part of the job. As part of the implementation of this model, we would include some sort of introduction to quality in the frontline EMS clinician's new employee orientation. That orientation would explain the organization's quality program and how improvements are driven by data, and how each emergency medical dispatcher, medical first responder, EMT, and paramedic plays an important role in collecting that data. In our first webinar for this series, GEMS Editor-in-Chief A.J. Heitman was our moderator. He made a comment that strongly supported the idea of giving quality training to new EMS staff. Let's take a listen.
My first comment personally is that that's the kind of presentation that every brand new EMS cadet, EMT, paramedic should get when they're in their basic training, so that they really understand why we're asking them to do all of this stuff.
The new employee orientation on the team-based quality program model would not only explain the quality program, but it would also explain their role in participating on clinical specialty teams, ad hoc improvement project teams, and supporting those clinical improvement efforts with good data collection and documentation. A clinical specialty team is a small group of passionate staff members that takes on a stewardship role for a clinical area. They take responsibility for moving the quality and value of care forward in their clinical domain. Now, we might have clinical specialty teams in areas like cardiovascular care, trauma, sepsis, and perhaps some other procedural, functional, or patient categories like airway management, emergency medical dispatch, and pediatrics. The clinical specialty teams are responsible for making recommendations to the EMS medical director and the EMS administrative director on changes to protocols and the associated processes used in that care. They're also responsible for developing the agency's continuing education modules related to their team's clinical domain, or at least being the subject matter experts for them to support the curriculum development with the training department. To do this well, the members of a clinical specialty team are supported by management to become the go-to in-house experts in their respective clinical domains. The clinical specialty team members embrace the opportunity to get more in-depth education in their clinical area by various mechanisms that might include keeping up to date with the latest research and best practices in medical and trade journals. It's amazing what can be done online with today's meeting technology. So it's quite feasible and relatively inexpensive to have clinical specialty teams conduct most, if not all, of their activities online. Some of these meetings may be live via video conference with screen sharing, whiteboards, and other online live meeting tools. And of course, traditional telephone conference calls can work too. However, most of the team activities can be done using asynchronous tools like virtual team workspaces, message boards, and email. By using a predominantly asynchronous meeting strategy, the team can avoid many of the delays and hassles of scheduling meetings, and it can avoid the potential expense of team members being required to participate off-duty with pay. Now, note that the clinical specialty team is not who conducts the actual improvement projects. An ad hoc improvement project team does. Ad hoc improvement project teams, as the name implies, are ad hoc, temporary. They are formed, complete their very clearly defined improvement project objectives, and then disband. Their temporary structure allows a broader group outside of the clinical specialty teams to get involved in the improvement process through project team participation. If we're talking about a clinical specialty team at an ambulance service, their ad hoc improvement project teams might include other staff members from inside the ambulance service, as well as external individuals from non-transport medical first response agencies, hospitals, 911 communication centers, specialty physicians, etc. The ad hoc improvement project teams will typically be led by someone from inside the clinical specialty team that spurred the creation of the project teams. But who leads the clinical specialty team? The model for the EMS clinical specialist is analogous in many respects to the model in nursing for the various types of clinical nurse specialists, and also bears many similarities to training physicians in residencies and fellowships for their respective specialties and subspecialties. And all of those models can trace their roots back to the craft guild model that we talked about in the first module of this series, where apprentices underwent an extended period of experiential learning to become fully credentialed journeymen in their craft. Above and beyond the standard clinical training of a paramedic, the EMS clinical specialist undergoes a substantial amount of additional training and preparation to take a leadership role in clinical quality for their selected specialty area. The additional training is not just in the specific clinical area, but it also includes training in quality improvement science, research, adult education methods, team and project management, as well as general management and leadership. Their didactic education is complemented with experiential learning through clinical and non-clinical rotations at area institutions and companies. Now, this EMS clinical specialist model is not really new. It is based in large part on a paramedic fellowship program that was originally implemented in the early 90s in Pinellas County, Florida, and later replicated under the leadership of Todd Hatley at New Hanover Regional Medical Center in North Carolina with funding from the Duke Endowment. And perhaps not coincidentally, this happened while Bill Atkinson, another EMS thought leader and former paramedic, was serving as the hospital's CEO. However, these original paramedic fellowships did not have a specialty focus. The one in Florida ran in parallel with an early EMS physician fellowship program that was also in place there. The paramedic fellowship was trying to prepare participants for roles that would have them working side by side with those completing EMS physician fellowships. We wanted them to become teams that were ready to make great things happen. It also turned out to be a wonderful succession preparation program for the next generations of leaders in that system and in other locations where the paramedic fellowship participants happen to go later in their careers. Now there are plans well underway to launch this team-based clinical quality model, including the EMS Clinical Specialist program, at a couple of EMS agencies in Colorado, the Trinidad Ambulance District in southeastern Colorado and the Upper Pine River Fire Protection District in southwestern Colorado. Why there? The key to making innovative projects like this work are people called champions. Champions in this context are people who want to make something happen. As it says in this definition, they voluntarily take extraordinary interest in the adoption, implementation, and success of a cause, policy, program, project, or product. Effective champions are willing and able to push through entrenched internal resistance to change and will evangelize it throughout the organization. In the Trinidad, Colorado Ambulance District, we have a champion for this effort, their executive director, Dan Moynihan. He actually worked in Pinellas County, Florida when the original paramedic fellowship program was taking place and witnessed its impact on the system and the participants. At the Upper Pine River Fire Protection District, we have a champion with their chief, Bruce Evans, who many of you in the EMS and fire community will know from his frequent presentations at national conferences and as a prolific author, including a textbook on EMS quality management and research. Now, it's important to note that the team-based clinical quality program model and the EMS Clinical Specialist program are not American College of Cardiology programs at this point. They're just innovative projects for now, and who knows where the model may go in the future. However, somewhat in anticipation of all this, the ACC is creating a new membership category for EMS professionals that have a passion for cardiac care. This will be a place where the future cardiovascular clinical EMS specialists, other members of an EMS cardiac clinical specialty team, and other EMS cardiac care champions can go for professional growth, support, and collaboration with cardiologists, cardiovascular clinical nurse specialists, and other members of the cardiovascular care team. Notice that a very interesting professional development pathway for EMS clinicians emerges from all of this. As a frontline EMS staff member, you participate by contributing high-quality data in your clinical documentation. And then, as you see opportunities it presents for your career and professional development, you step out from the pack by offering to work on some ad hoc project improvement teams. You might find that you like working on the improvement projects and want to have a broader opportunity to help shape how EMS is practiced in your agency. This might lead you to join a clinical specialty team in a clinical area you are particularly interested in. You start getting into improvement science at a deeper level, get into some research, and enjoy the additional clinical and non-clinical learning that takes place through the team. That might set the stage for you to undertake the challenge and opportunity to start down the path of becoming an EMS clinical specialty in your area of interest. Then, after you reach that laudable milestone and continue on in your career, you may choose to stay in a clinical leadership role, maybe start applying for grants to support your research and improvement interests, and maybe even supplement your income from those activities. You might also consider moving into other areas of management and leadership in EMS, maybe becoming the lead clinical manager, that key person in the EMS agency that works side by side with the EMS medical director and the EMS agency director or chief, and maybe moving into the top management spot yourself at some point, there or with another agency. There are also opportunities for you to now practice improvement science in other parts of healthcare or in other industries. The point is that the EMS clinical specialist has more clinical and QI-oriented options for their career path. Those aspiring for clinical leadership positions now have a program to participate in with rich experiential learning opportunities along the way. While these program models were not designed to bypass traditional college degree programs, They might provide an alternative pathway that some working EMS professionals may find advantageous. Indeed, some elements might get incorporated into collegiate programs. The hope is that the EMS Clinical Specialist program model develops a high level of visibility and a positive reputation through the improvement projects, research, publications, and presentations that are generated by program participants showing their team accomplishments at national conferences and in trade and peer-reviewed journals as their work starts flowing out from the pilot sites and other early adopter systems over the next few years. Those who complete the EMS Clinical Specialist program will come away with their own project and publication portfolios and documentation of their other program activities. They should come away from the program with a pretty good start on their curriculum vitae that they will keep adding to for the rest of their career. All of that combined with the strong positive reputation of the EMS Clinical Specialist program itself will hopefully give them a significant competitive advantage in the job market. More details on clinical specialty teams, ad hoc improvement project teams, and the EMS Clinical Specialist program model will be presented in future webinars. If anyone is interested in implementing the team-based clinical quality model and would like some support, please contact me for details. Earlier, I mentioned that an EMS provider agency might have the quality manager and the EMS medical director represented on a senior management committee where some sort of clinical performance measures are reviewed along with the performance of other parts of the organization. That senior management team plays an important role in this team-based quality model as well. How well is the EMS organization performing overall? Since EMS organizations exist primarily to provide pre-hospital medical treatment and transportation, there should be a way of measuring how well the community and patients are being served and how that performance is changing over time. Is it getting better, worse, or staying about the same? There should be several areas that the senior management team considers, but integral to the core EMS mission are the clinical service areas. In hospital parlance, these are the clinical service lines. So at a top level, each of the clinical specialty teams reports up to the senior management team. It is envisioned that the various clinical specialty teams would present their most recently calculated performance measures as the latest data points on run charts showing how performance for their key measures are changing over time. They would highlight the progress being made on each of their ad hoc improvement project teams and propose new improvement project teams. This allows the senior management team to fulfill one of their key roles: to approve, put on hold, recommend revision, or reject improvement project proposals. They should consider the proposals in context of the organization's overall needs, priorities, and availability of resources. There may not be resources to support every proposed project simultaneously. Some projects may not align well with the organization's goals, and so efforts and resources may be better used elsewhere or at a different time in the larger scheme of things. At the senior management team meeting, each clinical specialty team might also outline what training they recently created or presented, along with any before and after impact on relevant clinical performance measures, and any training modules in the queue for presentation before the next top-level management review. I should mention at this point that the idea of clinical specialty teams taking stewardship of a key organizational process and then using ad hoc improvement project teams to capitalize on improvement opportunities does not have to be limited to clinical operations. An EMS organization might also use this model with minor adjustments for other key areas like fleet management, HR, training, dispatch, etc. Perhaps those are simply called process teams, so we might have the fleet process team. The fleet process team would obviously include frontline fleet mechanics, but also frontline field crew members that have an interest in fleet issues. And just like a clinical specialty team, they measure, track, and report their performance to the senior management team, identify improvement opportunities, recommend formation of ad hoc improvement project teams, and take stewardship and responsibility for moving things forward over time. Now, let's talk about some of the limitations of the model we have presented. Right up front, I'll say that the model, as presented without any modifications, is best suited for agencies where crews do not have shifts packed full of calls. The model tries to take advantage of some of the downtimes that crews may have between calls and other duties. At busier stations or with dynamically deployed units that have higher utilization, the easiest and most expensive solution would be to pay overtime when participants are addressing these added responsibilities. That's likely to be a deal breaker for most organizations, at least as the primary mechanism. But there are some other options. You might try to get a greater share of participation from crews in slower stations, or have some time specifically set aside for some crew members in busier settings to participate in these sorts of activities. That might be in the form of special schedules for those serving on clinical specialty teams. Perhaps a special temporary schedule for ad hoc project team members could be arranged. It really takes a commitment from the management team, and if they have the will, they can find a way. It also assumes that the workforce and organizational culture is such that you don't get a lot of pushback on the idea of frontline staff taking on some additional responsibilities. You may need to start small, develop some trust, and create interest from the front line to get their buy-in. There may be union contract issues to consider as well. So let's recap all of this from a 20,000-foot level. With our goal of getting more clinical improvement projects done and getting our workforce more engaged in advancing clinical quality, we see that we might go from one person trying to carry it all to taking on this team-based quality program model that has several teams of frontline staff engaged through clinical specialty teams and ad hoc improvement project teams. We see the senior management team at the top with the various clinical specialty teams reporting up to it, and it assumes that the EMS medical director and the clinical quality manager are on that senior management team. Each of the clinical specialty teams has a variable number of ad hoc project teams running at any given point in time. We see that the field staff can be part of the ad hoc project teams or the clinical specialty teams. We see an infrastructure emerge that has several clinical specialty areas, each supported by their own clinical specialty teams. They each take stewardship of a clinical domain and identify improvement opportunities that then lead to the creation of the ad hoc improvement project teams. We also see a clinical education infrastructure where the clinical specialty teams take on the responsibility of creating clinical training for their areas or serving as subject matter experts to support curriculum development in collaboration with the training department. We see that members of the clinical specialty teams start getting more education in their respective clinical areas, quality, and research. We see the emergence of EMS clinical specialists in particular areas, and they get lots of additional didactic and experiential education that prepares them to lead the clinical specialty teams in their area of specialization. We also see how these opportunities for frontline staff engagement can be a great way to groom EMS professionals for a wide range of management positions and provide more career pathway options. So that's what the team-based clinical quality model looks like in broad strokes. We've covered a lot of material, so let's take some questions and comments.
If you're watching this live, please enter any questions or comments in the question box, and Tim and I will pick some out to address on air with our remaining time.
And if you're watching the archive recording of this webinar, feel free to send questions and comments to Mick. So you can contact him at mic@improvethesystem.com. The archive recording will be posted within a few days after this live session with an email notice and a viewing link sent out to everyone who registered for the event. Mick will then do his best to respond to questions and comments that he receives via email.
And while we're waiting for some of those questions to come in, I just want to say excellent job, Mick. That was incredible information delivery, and I really appreciate the work you put in and the production values. It's obvious you've spent a lot of time making sure that everyone that's tuned into the webinar today learned a lot, and so thank you for the effort that you put in.
Well, thanks, Tom. I'm a man on a mission. What can I say?
Well, we did get a couple of questions in, and before we address the questions, just want to encourage if there's anybody else who's been thinking about some to go ahead and submit them. And Mick and Tom, before we get to that first one, so just being completely forthright and honest here, I think this is the third time I've seen this. And the first time I went through it was just completely 30,000 feet. The second time I went through, I was really trying to pick up the points, and I kind of immediately started to get it, and then my mind went to implementation. And I guess, Mick, one of the things I just wanted to ask you to just speak to specifically while we're getting some more questions is, so in the video, you even stated that, hey, you know, there's a lot of things going on here, and you said something to the effect of, you might even need to start small and get some initial successes. So how about this, Mick? Imagine you're talking to somebody who kind of wants to be a champion, maybe feels a little overwhelmed. What could be some concrete, simple starting points to kind of get the ball rolling and get some of those smaller successes that you referenced?
Well, I guess the way I would suggest getting started on this model is with a small project, so you do get that early win, and try to identify something perhaps that your department is planning on doing anyway. Maybe it is working with area hospitals to do pre-activation or a direct-to-cath lab protocol. Maybe it's instituting high-performance CPR. Maybe it's some sort of a sepsis screening model and developing a formal sepsis alert program. Whatever it might be, take something that you're already going to do and maybe try to craft it in the image of this model and establish an ad hoc improvement team to do it. The other thing I would recommend is consider where you might want to start your first EMS clinical specialty team. So if that's a cardiology project, maybe you establish your cardiovascular clinical specialty team, and they kind of write up the project charter for the ad hoc improvement team, and we'll talk about project charters a little bit more in a subsequent webinar. But then that would then spur the development of the ad hoc improvement project team, and off to the races you go. And as mentioned earlier, we'll try to give you more information about the details on how to actually implement that.
That is a really good point, Tim, and I'm glad you asked that, because it's just so much information. It's you can tell that it's really credible, but in a way it feels like a really big ask, that this is going to be a major change to the way most EMS systems operate. And for example, on Hilton Head Island, we're already leveraging most of our top performers in various initiatives, whether that's because of accreditation or ISO or the training advisory board or their field training officers. So I think you're spot on, Tim, in saying like to start small and kind of proof of concept, because like we already have a strategic plan that's been formally accepted by the town council and things like that. So Mick, in Pinellas County or throughout your travels, have there been other systems like that have operated this way? Have you seen other than inside a hospital, are there EMS systems that are currently functioning this way?
I think there are, but perhaps not as formally. I think a lot of EMS organizations, regardless if they're private, third service, fire-based, volunteer, et cetera, have employee participation programs of some sort or another, kind of leveraging on the legacy impact of Duran, Deming, and Schuhart by engaging frontline worker participation. So they might be special project teams or something, but they're usually not in such a formal context. And that's really what I'm advocating for, is with the clinical specialty team, they formally take stewardship of a clinical area and with that, they measure the performance of those clinical processes and outcomes on an ongoing basis, and monitor the literature, monitor best practices, and when they find something, they think, how could you implement it here? And then when they find that opportunity, that's when they try to get an ad hoc improvement project team started to take that specific on. So I think a lot of organizations do this in some way, shape, or fashion. This is just trying to amp it up and formalize it.
Well, definitely. I think there's, meetings in general in the business environment are kind of unpopular. And so I think a lot of committees, especially if they're ineffective, kind of limits employee participation. But I like the fact that this is improvement focused, that they're targeting a particular clinical area or a particular problem. And I think if your staff saw that the result was that things actually improved and got better. Mike Tagman, one of the, obviously a quality guru, I loved what he said one time when someone was asking about their quality improvement program. And they were like, well, this is what we're doing. Is this considered quality improvement? And he said, well, ask yourself a simple question. Is quality improving? And if the answer is yes, then you're doing quality improvement. And if the answer is no, then you're doing something else.
Yeah, showing slides on how many IVs were started last month, maybe.
Yeah, who cares, right?
Yeah.
So we have a question from Jason Hatfield, and I think if you don't mind going back a little bit, I think this is mostly in reference to that, the e-reports EMS, the NCDR e-reports EMS. The question is, we have participated in AHA Mission Lifeline for the past 4 years. How is this different from AHA Mission Lifeline's EMS recognition? And second is, will false activations be tracked? Because Jason feels that's one thing that has been lacking in the EMS recognition.
Great. Well, thanks for asking the question, Jason. You can do this team-based quality improvement model regardless if you're participating in Mission Lifeline or your local trauma systems of care programs or stroke initiatives. It really doesn't matter. That might be the group that you work with at a systems level, and actually structuring your system to improve quality will actually be the topic of our next webinar. So we'll get into more details about that there and how these efforts can mesh in with things like Mission Lifeline, local trauma committees, and the like. With regard to the false activation rate, the initial release of e-reports EMS will not be tracking that. That is something that we are actively working on. It would require a little bit of a change in the registry, in that right now the registry only captures data on patients that actually had an AMI. So if EMS thought there was an AMI, turns out they didn't go to the cath lab, there isn't a registry record even entered. But that is an issue we are very, very aware of and working actively to get that captured in some way, shape, or form with a future release of the product. But it won't come out at product launch, unfortunately.
All right. We know, Mick, James had a question. It's kind of under that category of reporting as well. So I'm gonna hit that now. Here is his question. How does it affect the facilities report to ACC Cath PCI registry, but not action or chest pain registry? What is the game plan to get all hospitals on board?
So again, this particular program is registry agnostic. Whether you are using a local homegrown registry with your hospitals to track outcomes, or one from the ACC or the AHA or American Trauma Society for Trauma, et cetera, doesn't really matter. The issue here is that there is measurement taking place. There is some accountability established within the EMS organization for keeping track of that and looking for opportunities to improve, and then actually embarking upon improvement projects with accountability to the senior management team for actually making a measurable improvement. And this structure is designed to accommodate that rather than having that one lone quality manager trying to carry all the water here.
Thanks, Mick. Here's another question from Harold Cohen, and he makes the comment that use of clinical nurse specialists, PAs, or even physicians may be helpful in initiating quality management. Unfortunately, he says, some EMS systems believe that just because a person is a nurse or a physician assistant, they automatically qualify as a quality manager. So regardless of someone's clinical qualifications, he asks, what should EMS be looking for in a quality manager?
Oh, great point, Harold. And I would agree with your comment. Just because you have the clinical expertise doesn't mean you've gotten the additional training in quality and management in general. And so with the EMS Clinical Specialist program, that's very much going to be part of the curriculum, is learning the art and science of improvement, along with experiential learning to improve their clinical background and preparation and expertise. So you really need both. And if you did go the pathway of bringing in a mid-level practitioner to lead the quality program, I would treat that the very same way you would taking one of your best clinicians and putting them into the quality manager role. They're a good clinician, but they do need a clear development plan to get those knowledge and skills under their belt and prepare them to really take on that responsibility, because as you point out, Harold, it's not part and parcel to the higher level of clinical training they received. It's something in addition to that that's really needed.
Well, Mick, we are definitely getting some questions in here. I don't know if we're going to have time to get to all of them. Several of them would fall into the category of implementation. I mean, one of them was just simple, straightforward, hey, this is great. How would you implement this in an EMS system? Others were potentially a little more nuanced, but could you just speak to that? I know we have some upcoming webinars where you're gonna provide some of the recommended education that you reference in here. But if you would just speak to, again, that whole question of implementation, that just seems to be something that's really resonating with folks.
Yeah, so I'm glad people are jumping towards implementation, which, ideas are great, but execution is everything. And to execute on this well, I would start with having a conversation with your management team. You might end up being the champion advancing implementation of this model within your agency, which is great. And as mentioned before, find something that the organization is planning to do anyway or has been itching to do. Like direct to cardiac cath lab protocols, or starting a sepsis screening program, or starting to screen for large vessel obstruction strokes, whatever the case may be, something the organization was already planning on doing it, and try to craft it in the mold of an ad hoc improvement project team. And there will be a webinar about doing that here in the not too distant future. And maybe using that also as the launch point for the associated EMS clinical specialty team. That is where I would recommend getting started anyway.
Well, and then scanning some of the other questions, I'd say you're scratching where people are itching, because now there's several questions about, hey, are you proposing a formal clinical specialist course? Where is that offered, and whatnot? So
yeah, so well, no, that's great. As mentioned in the presentation, we're going to start with a couple early adopter pilot sites in Colorado. We might add a couple more, but we plan on trying to publish and present on the experiences of those early adopter programs as much as possible, and trying to roll out some education for that. Kind of my longer term vision is that, say, the cardiovascular EMS clinical specialty teams around the country would have a way to talk with each other. And let's suppose they all want to work on a particular new project. whatever that might be, some point in the future, we're going to start giving thrombolytics in the field all over the place, or using some new gadget to do detection of stroke in the ambulance without having a big CT scanner in there, maybe some sort of football helmet with ultrasound, or there's a bunch of stuff around that looks promising in that regard. But instead of your agency doing it all alone, maybe you're partnering with other similar EMS clinical specialty teams to do a project together, is where I'm kind of hoping this will all lead. And then we have these, large and multi-institutional research studies that are coming out of EMS.
Well, guys, I hate to say this, but we are getting close to the end of our time here. So before we wrap up, can we get some final closing comments from you two?
Tom?
Sure. I mean, I think one of the main things that I'm taking away is, and Hilton Head Fire Rescue already uses, we call them working groups. We used one as a PCR evaluation team. We have one for pediatrics, one for airway management, one for portable medical bags and things of that nature. And I'm starting to realize that the ones like the PCR selection and the portable medical bags are pretty close to ad hoc improvement teams. And the one for pediatrics and airway management, I think are fairly close to clinical specialty teams. So I guess I'm wondering if this is something that I should formally transition to, is a clinical specialty team. And then I'm wondering then what my role then should be, if I should like step back, if I should still be a member of these teams. So maybe as a final thought, Mick, you could help, because other people in the questions were asking about top-down implementation versus bottom-up buy-in. How do you, and I guess this will probably come from in future webinars, how do you balance that, empowering the line employees to have a say in what's happening while making sure you're keeping them between the ditches and making sure their recommendations are feasible and realistic?
Yeah, and that's a great question, but I will defer that to the ad hoc project team webinar and the EMS clinical specialty team webinars, unfortunately, due to our time constraints. But you're on the right wavelengths, Tom, with trying to take your existing efforts and just kind of recast them perhaps closer to this model, formalize it, establish some accountability, and hopefully you'll start reaping some of the benefits sooner than later.
I hope so, maybe with your help, Mick.
Okay. As far as my parting comment, I think that there's a lot of opportunity here. Obviously, I see this problem a lot throughout the EMS industry, where there's a lot of measurement and reporting, but I don't see a lot of tangible improvement projects. So that's part of what I'm trying to catalyze here. And the ACC obviously also wants to see that, particularly in the cardiovascular care space. And as alluded to before, the ACC is trying to expand its offering of EMS and systems of care related products and services to support that, starting a new EMS membership category, which I would anticipate that the cardiovascular EMS clinical specialists and maybe members of the cardiovascular clinical specialty team might really find useful, and good fellowship and camaraderie and networking opportunities there. So with that, we've done our closing remarks, and if anyone, go ahead.
Sorry, I think that was my cue. So unfortunately, we're out of time. For more information about the new eReports EMS reporting service for acute myocardial infarction that will be coming out soon, be looking for an announcement on a webinar specifically for it, which will walk you through the product and provide details about how to enroll and the costs, etc. To receive an email announcement when the date is set for the next and future webinars in this EMS and Systems of Care series, please send an email with your name, the name of your organization, and your email address to ACC webinar series at improvethesystem.com.
And I would like to thank Tim and Tom for their support as being our moderators today and weeding through the questions and kind of getting the ball rolling with some very insightful, provocative questions on their own. It's been a wonderful experience for me. I hope it has been for you as well. The best way, if you want to reach any of these guys, here's Tim's email address, tphelan@mac.com. And Tom is very active in social media, so here's his email address, his Twitter handle, and a place to find him on LinkedIn as well. So on behalf of the American College of Cardiology and the Center for Systems Improvement, thanks so much for attending today's webinar, and that concludes today's presentation.